I am full-time GI and SPB onco-surgeon at SGVP Holistic Hospital. Already my intro has been given. Now, I will today specifically speak on pancreatic malignancy. Okay, so I am following the guidelines of ISGPS, that is International Study Group of Pancreatic Surgery, and as India, as a country, we are lucky that this guy, Dr. Shailesh Shikhande, he is from Tata Memorial Hospital, Mumbai. He is in that group, and I have worked with him. So lot of things are there. We are doing something, then we have to follow some guidelines. It is not that, okay, I have this qualification, so I will do that. No, it is not like that. We have to follow some guidelines, and we have to decide by that, okay, we are in the right way or wrong way. So these are the data from Globacon 2022. Okay, this is from the India. These are overall, these are the overall cases of malignancy, not only pancreas in India. Okay, so now this is for the pancreas only, and this is only one thing I want to show, that the pancreas cancer incidence, the rank of the disease is 12. Okay, 12 number છે overall બધા કેન્સરમાં. But the problem is that કે mortality જે છે, the rank is 6th. અહીંયા તમે નંબર જુઓ, there are 5 lakh something is there, નવા કેસીસ થાય છે, and every year the mortality is 4.6. मतलब 5 लाख नवा केस डायग्नोस થાય છે, આમાંથી 4.6 lakh they are going to die. Okay, now this 3 slide, આમાં ખાલી કલર ઉપર જ તમે ફોકસ કરો, ગ્રીન કલર. Okay, this is from Asia, not India. Just see the incidence, mortality and prevalence. We are in the green color. Okay, so it is a worrisome feature for us. So the same, the disease has the very poor prognosis. What are the risk factor? We are in the dry state on paper, not off paper. Okay, so other features are the obesity, diabetes, heavy alcohol consumption. Okay, so we have to prevent that things. Okay, then we can get decreased incidence of the pancreatic malignancy. Now this was the paper published in 2020. So what will be the future incidence of malignancy in India? This is we can see in India, this paper was published in 2020. 1 in 9 people is likely to develop cancer. This is not for pancreatic cancer, this is for all cancer. Okay, so the incidence of cancer, what was in 2020, in 25 it will be increased by 12.8%. Nowadays આપણા જે બધા કોન્ટેક્ટમાં બધા ડોક્ટર છે બધાને આઈડિયા જશે કે we are seeing more cases of malignancy in comparison to older days. Okay, now for pancreatic malignancy, most common malignancy everyone knows, that ductal adenocarcinoma. Other is the cystic neoplasm of the pancreas. Others are very rare malignancy. Means rare means once in 3 or 4 years we will get that cases. Okay, so I will talk mainly on pancreatic adenocarcinoma, cystic neoplasm and the neuroendocrine tumor. So pancreatic ductal adenocarcinoma, જ્યારે બી તમારી પાસે પેશન્ટ આવે ઓબ્સ્ટ્રક્ટિવ જોન્ડિસનું અથવા એબ્ડોમિનલ પેઇનનું પેશન્ટ, સો વોટ વી વિલ ડુ ફર્સ્ટ થિંગ, વી વિલ ડુ ધ લેબ ઇન્વેસ્ટિગેશન એન્ડ અલ્ટ્રાસાઉન્ડ ઓફ એબ્ડોમેન. ઓકે, સો પેન્ક્રિયાટિક એડિનોકાર્સિનોમા પેશન્ટમાં જનરલી જોન્ડિસ ઇઝ ધેર, ઇટ ઇઝ ધેર. ઓકે, સો ultrasound was just we have to see, we have to rule out whether the most common cause of the jaundice is the CBD stone. જો CBD stone ના હોય અને પેશન્ટની એજ more than 50, then you have to suspect malignancy. It is the rule. 50 વર્ષની ઉંમર છે અને jaundice છે obstructive pattern means total bilirubin is 10 and direct bilirubin is around 7 or 8, or it is more than 30%, then it is a obstructive jaundice. Okay, so જે more common mistake જે પેશન્ટ અમારી પાસે આવતા હોય છે સિટી સ્કેન કરાવીને, જો કોમન મિસ્ટેક છે રૂટીન નોર્મલ સિટી સ્કેન કરાવે છે, તમે CBD સ્ટોન રૂલ આઉટ થઈ ગયા છે અલ્ટ્રાસાઉન્ડને, યુ આર asking them to do the CT scan, then just write one more, only 2 word, pancreas protocol. તમે CT scan કરાવો છો તો just pancreas protocol mention કરો. અલ્ટ્રાસાઉન્ડમાં તમને લોકોને આઈડિયા આવી જશે કે this is metastatic disease or not, liverમાં મેટ છે કે પેરિટોનિયમમાં છે, એસાઇટિસ છે, જો એવું બધું હોય તો આગળ કોઈ બીજી કોઈ વસ્તુ કરવાનો કોઈ મિનિંગ છે નહીં. બટ ઇફ ઇટ ઇઝ નોટ ધેર, then just mention that CCT abdomen with pancreas protocol. The advantage of this is that we will know whether the disease is resectable or not. It is not metastatic, but whether it has attachment with the portal vein, superior mesenteric vein, splenic vein confluence, or superior mesenteric artery itself. Okay. Second thing, CT chest or X-ray chest you can do in resectable or non-metastatic cases. Third thing, everyone is missing CA99 and CEA. That has to be done in all cases if you are suspecting malignancy. હવે બહુ મોટો ગ્રે ઝોન છે ખરેખર. It is we are seeing lot of problem in this gray zone: ERCP stenting, PET scan and EUS. Okay, what is the role of the ERCP and stenting in operable cases of jaundice? We have operated of the cases with bilirubin of 44. They are going uneventful, nothing is there. Okay, what is the role of ERCP and stenting? Upfront cases ni andar there is no role. Operable cases ni andar no role. કોઈ મીનિંગ જ નથી ERCP અને સ્ટેન્ટિંગ કરવાનું. યસ, when there is role, when patient is having cholangitis, means patient ને ફીવર આવે છે with chills and rigors, tachycardia is there, hypotension is there, then suspect cholangitis, then we have to do the ERCP and stenting. Okay, first thing. Second thing, ERCP કરીને બાયોપ્સી લેવાનો કોઈ મીનિંગ નથી. If you will do biopsy, you are opening the normal mucosa and you are allowing the normal intestinal flora to go in that part, and it will cause actually more cholangitis. Even ERCP પછી cholangitis વધારે થાય છે જે નોર્મલ પેશન્ટમાં થવું જોઈએ એના કરતા. Okay, second thing, once you will do ERCP just to take down the bilirubin down, that patient has to wait at least 3 to 4 weeks for the surgery. એક વાર સ્ટેન્ટ મુકાઈ જશે, then there will be severe inflammation and surgery will be more difficult. So ultimately we have done the procedure which was not indicated. Okay, and patient is at the lost. Money भी જાય છે patient ના, and patient has to wait more. Okay, now PET scan. Everyone is very means PET scan is એવું છે કે આવી ગયું છે એટલે બધું ક્લિયર છે. No, it is not like that. We are from India. We have still cases of tuberculosis and other infectious disease. તમે PET scan કરાવશો, બધા રિપોર્ટ વાંચેલા રહેશે, from the base of the skull આખી બોડીનું આવે છે. If you have cough, you have some infective etiology in your lung or wherever, it will take as a hotspot. It will show as a metastatic. It will not rule out that it is not metastatic disease. PET scan નો રોલ ક્યારે છે? When CA99 and CEA, they are in thousands. Okay, CA99 ની normal value છે 35. Okay, if it is around 100, 200, okay, no issue. But when it is in 1000, you do the PET scan. Okay, if it is metastatic disease, then patient will not go for unnecessary surgery. Okay. Third thing, endoscopic ultrasound. In operable cases, the last line, the red line, there is no need of biopsy for operable cases of CA as suspected by CT scan and clinical findings, because and biopsy negative આવશે, still there is malignancy and you have to operate the patient. So it is the wastage of the resources. Okay, many of the people I have talked, they are saying કે સર EUS માં અમે જોઈએ છે કે પોર્ટલ વેન ને SMV ફ્રી છે, but then what is the role of the CT scan? CT scan will give us the better idea, and that's why pancreas protocol I am writing. બધાને ખબર છે કે CT scan કરે ત્યારે આપણને પેલો કોન્ટ્રાસ્ટ પીવડાવે છે, but pancreas protocol ની અંદર કોન્ટ્રાસ્ટ નથી પીવડાવવાનું, ન્યુટ્રલ મતલબ પાણી જ પીવડાવવાનું છે. So vessel જ્યારે opacify થાય, then we can see, okay, there is the vessel, there is the lesion. Okay. So this gray zone is very actually what I want to convey by this main slide, the pancreas protocol. What is the need of the ERCP and stenting, PET scan and EUS? Okay. No role of MRCP at all. Forget about MRCP. MRCP no કોઈ રોલ જ નથી એની અંદર. You are suspecting hilar cholangiocarcinoma, मतलब કે લીવરમાંથી જ્યારે ડક્ટ નીચે આવે છે ત્યારે એનો રોલ છે. Still CT scan you have to do for operability to see the vessel involvement. Okay, MRCP તમે કરાવો છો તો હાઇલર કોલેન્જિયોકાર્સિનોમામાં it will give better idea, not in periampullary malignancy. Okay. Now for pancreatic ductal adenocarcinoma, Whipple's procedure, I think બધાને પહેલા એવું છે કે Whipple's procedure મતલબ 50% patient will go. No, it is not true nowadays. Okay, so Whipple procedure, when we have to do when the malignancy is in the head, uncinate process, or in the neck region. Okay, and what is when the malignancy will be in the body or tail? So what is the answer for that? It is the Appleby procedure or Ram's procedure. It is not the distal pancreatectomy and splenectomy. Malignancy ની અંદર કોઈ બી malignancy, not even pancreas, in all malignancy, if you are removing the lesion, you have to remove the locoregional lymph nodes. તમે 8 કલાકની કે 10 કલાકની સર્જરી કરો છો, but you are leaving some lymph nodes there, then it is better to not to do that surgery, because it will come with this recurrence within few months only. Okay, so Ram's procedure and Appleby procedure is for that only. Now this is the only slide. This is the Whipple's procedure case we have operated. This with the IVC, this is the left renal vein, this is the pancreas, and this is the after anastomosis. Now Whipple's procedure. Why everyone is so afraid of? Because અમારી પાસે પેશન્ટ આવે ત્યારે ઓલરેડી અમને એક્સપ્લેન થઈ ચૂકી હોય છે કે આ પ્રોસિજરના કોમ્પ્લિકેશન રેટ બહુ હાઈ છે, પેશન્ટ ઘરે નથી જતા. It is not like that. I will show my data. So it is a complex procedure, definitely. 8-9 પ્રોસિજરની મિક્સચર છે એટલે કોમ્પ્લેક્સ તો છે જ. એવું નથી કે તમે કોઈ એવું કહે કે 3.5-4 કલાકની અંદર મેલિગ્નન્સી માટે Whipple's procedure કરી છે, then I will doubt it, because just removing the lesion is not the Whipple's procedure. You have to remove all locoregional lymph nodes to give the clearance. And why we are doing the procedure? To improve the survival of the patient. 6 મહિનાની અંદર જો પેશન્ટને રિકરન્સ થવાનો હોય, then there is no role of doing the procedure. Okay, so dissection, meticulous dissection, hemostasis, resources we have to use intraoperatively to control chyle leak and for hemostasis. Okay, third thing, precise anastomosis, pancreaticojejunostomy, hepaticojejunostomy and gastrojejunostomy we are doing routinely in the cases, and we are getting nice result, but we are taking 4 hours to do only the 3 anastomosis. Okay, એકવાર તમે પેશન્ટને ટેબલમાંથી શિફ્ટ કરશો ઓટી ટેબલમાંથી, then you cannot say okay મેં એક એક્સ્ટ્રા બાઇટ લીધો હોત તો પેશન્ટ માટે સારું હોત. No, give proper time at the procedure. Okay, and post-op care. So કોઈ બી પ્રોસિજરને તમે ડિવાઈડ કરો 30-30-40 or 30 Whipple's માટે હું કહું છું 30-40-30. 30% means proper pre-operative evaluation, 40% intra-op care, and 30% is post-op care. Okay, now the main problem with Whipple's, only identification of the complication. Patient ने post-operatively tachycardia થાય છે, patient ने saturation falls થાય છે, then you think the first thing motor scar હશે, patient ને abdominal pain હશે, that will cause the atelectasis, or there will be leukocytosis will be there in all patient post-operatively temporarily. Okay, so think common first જે આ લખ્યું છે simple things first. Remove this the simple thing first અને પહેલા રૂલ આઉટ કરો, અને પછી સર્જરી પ્રોસિજરના જે ડ્રેન મૂક્યા છે, સર્જિકલ પ્રોસિજર એબ્ડોમેનની હોય તો એમાં ડ્રેન મૂકવાની જ હોય છે. Then brain will say okay this is the problem. Okay, now Whipple'sમાં જે recurrence થાય છે, whether it is the failure of the procedure itself or it is the residual disease. मतलब એવું છે કે આ residual disease છે કે recurrent disease છે, that is the main problem. Okay, because I don't know આમાંથી કેટલા લોકોને ખબર છે કે Whipple's procedure ના કેટલા ટાઈપ છે. there are a lot of other types, અને અત્યારે ઘણા રિફાઇનમેન્ટ આવ્યા છે કે આ એક જગ્યા છે જે જગ્યાની અંદર તમે લિમ્ફ નોડ રિસેક્શન સ્પેસિફિકલી ફરીથી કરો તો તમને એમાં વધારે લોંગ ટર્મ આઉટકમ મળે છે. આઈ થિંક ઇન 2023 એશિયા પેસિફિક HPBની જે કોન્ફરન્સ થઈ હતી, ડૉક્ટર માર્કસ બુકલર, he is the pioneer of the pancreatic surgery. Okay, so he has said, actually હું પણ એમની વાત એ નહોતો માનતો એ વખતે, he has said he has got 44% 5-year survival for the Whipple's procedure pancreatic malignancy. I am not ready to believe, but he has shown his data. and he will publish. You can search in Google, Dr. Marcus Buchler. Okay, he is from the Heidelberg, Germany. He is the father of pancreatic surgery. Okay, so there are types of the pancreas surgery. One operation, what he is saying, replace કરવાનું છે, but specific portal vein, superior mesenteric artery અને celiac artery, જે celiac trunk આપણે કહીએ છીએ, એનો જે ટ્રાયેંગલ થાય છે, એ ટ્રાયેંગલની અંદર મેક્સિમમ નોડલ રિકરન્સ થતું હોય છે, that we have to remove. Okay, that I am following that thing. Okay, that types એ આવી ગયા. Now staging laparoscopy. સ્ટેજિંગ લેપ્રોસ્કોપી મતલબ જે આપણે ડાયગ્નોસ્ટિક લેપ્રોસ્કોપી કહીએ છીએ સેમ. વોટ ઇઝ ધ રોલ? પેશન્ટને તમે મોટો ઇન્સિઝન મારો છો એ પહેલા જસ્ટ પુટ અ લેપ્રોસ્કોપ એન્ડ સી વેધર એની મેટાસ્ટેટિક ડિસીઝ ઇઝ ધેર ઓર નોટ. ઓકે, દેન વાસ્ક્યુલર રિસેક્શન એન્ડ chemotherapy and borderline resectable. Vascular resection cases have very much complication rate high. That should be done in only high volume centers. So far in last I think first Feb 24 to today, I have done 25 cases of people. We have no in-house mortality at present. One patient we have lost after 1 month at home because of the cardiac cause. One more patient recently came in the OPD with liver mets because he has not taken the chemotherapy. So this is all for pancreatic adenocarcinoma. 2 minutes more. Now cystic neoplasm. Pancreatic adenocarcinoma નું prognosis comparatively ખરાબ છે, but cystic neoplasm they have very good prognosis. Patient can live normal life. So આ ઇમેજ તમને બધી HPB ની કોન્ફરન્સમાં જોવા મળશે. If any daughter in 2030s એને કોઈ cystic lesion છે pancreasની અંદર, then it will be span solid pseudo-papillary lesion. જો એની મધર મતલબ 40 to 50 yearsની એજ, then it is a mucinous cystic neoplasm. It has the malignant potential. It has to undergo surgery. And grandma, मतलब जे 70-80 ની એજ છે એની અંદર cystic lesion આવે, that will be serous cystic neoplasm that can be observed. So now role of the EVS will come in the this cystic neoplasm to characterize the internal septa and what is the this mucin is there or not. So એના માટે શું procedure છે? Whipples is there. Segmental resection, distal pancreatectomy and Ram's procedure. Now I will show you some photos only. This is the distal pancreatectomy with splenectomy for cystic neoplasm. This was the MCN without invasive component. This was the span, solid pseudo-papillary neoplasm. And this one more interesting case. Last year I got this patient. Presentation of the patient was hematemesis and melena. Okay. So EGI-scopy was done. There was mass in the stomach. Okay, a biopsy was came as a mucinous cystic neoplasm. So patient was already told कि घरे सेवा करो. Then we have done the CT scan. It was operable. We have operated the patient. Today patient is alive, doing everything by herself. Okay, this is pancreatic stump. આ જે congested mucosa દેખાય છે, that is stomach mucosa. Okay, and this is jejunum because it was infiltrating into the stomach above, below into the jejunum. So we have done this complex procedure, and this was the open stomach. This is what repaired intraoperatively, and this is actually my old slide what I have put the WhatsApp status at time to show the people. This patient was started on SIPS orally on POD1, on full liquid diet from POD3 and discharged on POD5. 25 lymph nodes was removed, all were negative. But આ પેશન્ટને MCN એવું છે કે બે કમ્પોનન્ટ છે, it is invasive or not invasive. So it was invasive, so patient has to take the chemotherapy. Otherwise cystic neoplasm there is no need to take the chemotherapy. So this was the Ram's procedure. Actually जो कोई identify करता है तो this is aorta. Okay, this is left renal vein, this is the left kidney, this is the superior mesenteric vein. જે બોડી અને ટેલના પેન્ક્રિયાસના કેન્સર હોય છે, they will directly infiltrate the celiac trunk and common hepatic artery. So આની અંદર આખું arterial divestment મતલબ જે adventitial tissue હોય છે, આપણે ફર્સ્ટ યરની હિસ્ટોલોજી, adventitial tissue was removed from the common hepatic artery. And this is the same case like this only. This is for the body and tail, not for the head cancer. So what I want to convey that pancreatic cancers are operable, curable, બટ વી હેવ ટુ આઈડેન્ટિફાઈ દેટ સબસેટ અર્લી. જે પેશન્ટ એવા છે એમને અર્લી આઈડેન્ટિફાઈ કરો. ડોન્ટ ડિલે ધ ટ્રીટમેન્ટ ફોર ધેમ. ઓકે, ફોર એની ક્વેરી યુ કેન કોન્ટેક્ટ મી. This is my mail ID. Thank you very much. Thanks.